So our next speaker is Dr. Andrew Nelson, who's currently an assistant professor and soon to be an associate professor, hopefully, at the University of Minnesota. He did his anatomic pathology training and molecular and genetic pathology fellowship here at the University of Minnesota, and has been on faculty ever since. And he's been heavily involved in a research project looking at ovarian cancer and precision medicine advances in that particular tumor. So he's going to talk to us about the work he's been doing along with his collaborators.
Fantastic. Thank you, Bharat. And again, thanks to Dr. Pritchard, because he really set the stage, I think, with some foundational concepts that I'll touch on and even show some anecdotal evidence from our pilot patients within this cohort of just how much value there is there. Probably gave me too much credit on some of the things that I was going to dive in deeply to, which given 30 minutes, I'll probably just glance on them. But hopefully you all now have a nice introduction to some of the key components of what I'm going to be talking about based on what Colin's kind of presented. So no financial disclosures. We do have collaborations with private entities, including some for-profit and not-for-profit entities. Just wanted to call those out with Senti Biosciences and Sage Bionetworks. I have, because of limited time, ruthlessly pillaged some of this material from some of my colleagues within this very large project. So many thanks to them, and it's probably too long, so I'll probably be kind of going at a fast pace, but hopefully you won't hesitate to jump on the boat and set sail with me through this adventure. Right here over on the right-hand side, that's us and TM2 leading the pack. So that's my wife and I. Briefly, what I hope to take you through today, set the stage with what are the challenges that led to us initiating the Ovarian Cancer Precision Medicine Project. And basically what this is it's kind of a journey through how do we use multi-omics to characterize disease and learn more about it from the germline all the way down to the single cell. The first concept that I want to introduce to the audience is just how much histologic and genomic heterogeneity there is within epithelial ovarian cancer. This is not uncommon. It is something that we see across all of the different disease states, solid tumors that we study. Dr. Pritchard, of course, could take us through the adventures with prostate cancer if that was kind of a big part of his talk as well. So when we look at the four major histotypes of epithelial ovarian cancer, we have mucinous, endometrioid, clear cell, and high-grade serous, which you see pictured here, which all have distinct appearances under the microscope. And of course, those distinct appearances under the microscope actually reflect distinct biology that's going on underneath it. When we look at the DNA mutations that are most prevalently found in those different histotypes of epithelial ovarian cancer, you can see that there are some commonalities between different types, such as ARID1A and clear cell and endometrioid, but those are distinctly different across the four different histotypes. One thing that I'm going to get into and is a major focus of the OCPMI is understanding therapy resistance. And the other thing that we have gained more knowledge over the last decade or so is the intrinsic platinum resistance that can be associated with specific histotypes within ovarian cancer. So clear cell and mucinous invasive adenocarcinoma originating from the ovary of the fallopian tube all demonstrate intrinsic platinum resistance, which is crucial because that's really been the mainstay of adjuvant chemotherapy for this disease for a long, long time. But we know that those particular types don't respond terribly well. When we look at copy number alterations at a segmental level across the entire genomes, this is data from other groups that was published in Cancer Discovery in 2016. And this specifically was high-grade serous ovarian carcinoma, which is the most common subtype of epithelial ovarian carcinoma. We can see when we look across individual patients, each indicated by the number, that we see some commonalities where there are some segmental deletions and some gains that are reasonably common across different patients. But then the authors took it and even dived deeper. They went down and they looked at something called serous tubal intraepithelial carcinoma, which is essentially a precursor of high-grade serous carcinoma that arises within the epithelium of the fallopian tube. They looked at invasive components of the tumor that were on the fallopian tube versus the ovary, and as well as metastatic omental implants. And within individual patients, you can again see that sometimes there are shared features across all of those sites. But in some patients, there's a tremendous amount of variability, not only again between individual patients, but between individual sites of disease within the same patient. So we're dealing with a very biologically and genomically heterogeneous disease, and we have to understand how that impacts patient outcomes. And that is the problem in epithelial ovarian cancer, is that survival remains poor. So when we look at the graph on the left-hand side, over the last 30, 35 years or so, we can see that the 5-year survival in ovarian cancer has remained relatively flat, about 35% or so in 1975, and just now tipping the scales at about 45% as we got into the 2010s. Now, as we've learned more about serous ovarian carcinoma, we've broken it down into what we think are molecular and biologically meaningful subtypes. I'll talk a little bit more about that in a few slides from now. Some of those are seen here, and we do see that there are some prognostic differences. There are subgroups such as the differentiated and the immunoreactive, which have slightly better survival than other subgroups such as the proliferative and the mesenchymal. But the reality is that when you look at 5 years and you look at 10 years, no matter what, survival stinks. And so we need to figure out a way to bend those curves and bring those survival up. Historically, our gynecologic oncology surgeons, our colleagues, are the most key component to trying to treat this disease. The skill of the surgeon's knife and how effective they are in that debulking surgery really remains the key in treatment. If the surgeon is able to remove the vast majority of the tumor, survival for that individual patient will be relatively good, averaging around 40 to 45 months. If they cannot get the residual tumor below a cubic centimeter, survival is very meager at only 12 to 16 months. And again, historically, one of the reasons why we have not made a lot of progress is that adjuvant therapy has been one size fits all. So despite the fact that, as I said, we started to learn that clear cell and mucinous is actually intrinsically platinum resistant, across all of the histologic subtypes of epithelial ovarian carcinoma and all of the intrinsic biologic heterogeneity within types such as serous, which we'll talk about, we've still been using paclitaxel carboplatin regimens for essentially most of history up until recent time. The other component of the problem is that recurrence is very common, and once patients recur, the disease is no longer curable. It is uniformly fatal after that point. So most of the patients will relapse within about 18 months. The way that we try and clinically characterize disease, to study it and to understand what may be some of the biologic drivers of therapy resistant is based on the progression-free interval or progression-free survival after the last dose of platinum-containing chemotherapy. Those patients who have a progression-free interval greater than 6 to 12 months, we label as platinum sensitive, either partially if it's between 6 and 12, or fully platinum sensitive if it's greater than 12 months, that progression-free interval. Our patients who have progression within 6 months of going off of their last platinum-containing chemotherapy regimen are labeled as platinum resistant. And those patients who essentially progress on therapy are labeled as platinum refractory. And so part of our project is, again, to try and understand biologic differences in the tumors of these three types of patients. So hopefully what this introduction has shown you is that we need a paradigm shift. We need to better understand from a research perspective tumor heterogeneity and how to account for it diagnostically. What we're hoping to with our project, and many of our other collaborators and competitors are trying to do, is to uncover relevant pathways for novel therapeutic targets. We need to refine the molecularly distinct subgroups, which I'll go into in one of the next slides. And once we refine those molecularly distinct subgroups, we need to define what the subgroup-specific biomarkers are that can help us pick better targeted therapies to improve survival. So, as I introduced a few slides ago, and just mentioned to bulk gene expression studies of ovarian cancer have driven a molecular classification of the disease. So as I said, from the histology perspective, looking under the microscope, ovarian cancer is an incredibly complicated thing. We're just focusing on epithelial ovarian carcinoma. And in fact, predominantly what we're focusing on is the most common serous epithelial subtype. And so others, including the Cancer Genome Atlas Project in 2011, as well as other groups that published in 2008 and 2013, have essentially used gene expression profiles of bulk tumors to come up with what they believe to be molecularly relevant biologic subtypes, very much like Chuck Peru and Therese Sorley did in breast cancer 10 years before this in the early 2000s. And there, as I said, are essentially kind of 4 more or less consensus subgroups of molecular serous ovarian carcinoma. There's the immunoreactive, which seems to have some types of immune infiltration and immune milieu, but has not quite yet been translated into understanding how those patients may or may not respond to checkpoint inhibitors, such as Colin introduced earlier. There's the differentiated, which actually is, again, one of the better prognostic subgroups and tends to do relatively well. There's a proliferative subgroup, which has a overall worse prognosis, and it does have a little bit of overlap with the mesenchymal because this proliferative subgroup does express some mesenchymal markers. It tends to be a little bit more of an immune desert. And then there's the mesenchymal subtype, which again seems to have a lot of upregulation of markers that would be reflective of EMT or epithelial to mesenchymal transitions. And again, how this is done is through taking large sets of tumors, cohorts of tumors, and using some subset of genes. In the case of TCGA, it was right around 1,000 to look at up and down expression of particular subsets of genes that differentiate the biology. Now, the problems with this is that it is not particularly robust when we do it on a single patient level. So cohort assignment in something the size of the TCGA can be relatively accurate, but it's much more difficult to do this on a single patient level and actually be accurate enough to have some type of clinical utility. Furthermore, the reproducibility of the molecular subtype between different sites of disease, just as we saw with the copy number variation analysis I showed from that other group, is not particularly robust. And further, when patients are treated over time and their disease evolves, the underlying molecular subtype can change as well. So far, none of these molecular subtypes have led to any type of robust clinical utility for therapeutic prediction. So what we created about 3 years ago now was something called the University of Minnesota Ovarian Cancer Precision Medicine Initiative. And this was a University of Minnesota's Grand Challenges funded project. It's actually been funded twice now, in phase 1 and phase 3. The initial idea was to create a molecular precision medicine model on which we would do bulk and single cell molecular analyses on our ovarian cancer patients, as well as create REDCap databases to track treatment data and clinical response, with the goals of identifying cell types and signaling pathways through these multi-omic analyses. With the idea too that what we could do is try and compare therapy resistant and therapy sensitive cancers, as I was defining earlier, to come up with a better model to treat ovarian cancer, as well as create infrastructure, biobanking methods, et cetera, that could be distributed to new disease types like prostate cancer, GI cancers, et cetera. So on the right-hand side, I show what were essentially our hypotheses. They're really almost more of a mission statement. And what we believed and proposed was that comprehensive molecular analysis can provide clinically useful information to improve outcome in our patients when we integrate it across multiple different types of platforms. We posited that germline variation can predict therapeutic response, anticipate toxicities, and provide medical value to patients and their families. Again, as Colin nicely demonstrated in his talk previously. And finally, we propose that single-cell analysis will be able to identify subpopulations within the tumor microenvironment that can impact platinum-resistant, checkpoint inhibitor response, BEV response, PARP inhibitor response, and hopefully identify even new targets that we could pursue. So the Ovarian Cancer Precision Medicine Initiative was an intersection of two separate projects initially. The first was started by myself and Boris Winterhoff, a gynecologic oncology surgeon, which was largely a prospective data collection on our patients. We would recruit patients prior to their first debulking surgery, and as long as they were diagnosed with truly a malignant epithelial ovarian carcinoma in that surgery, they would basically become fully enrolled within the trial. From that point, we would acquire during surgery research tissue that we would biobank and use for different types of somatic sequencing analysis down the line, including single cell, ultimately in collaboration with TimStar. And we would also do germline sequencing of the blood. And now this would actually be clinically ordered. So we would clinically order BRCA1 and BRCA2, which is a considered standard of care germline analysis for all ovarian cancer patients. But then in a research return of results component, we would provide a much larger inherited cancer predisposition panel of 24 additional genes beyond BRCA1 and BRCA2, as well as based on patient preference and consenting, secondary findings, including medically relevant genes from the ACMG 59 list and carrier status for a broad list of approximately 94 different genes and conditions. Now, as I said, this was intertwined with TimStar and Boris's project for single cell sequencing of ovarian cancers. So what we were doing in that project is acquiring that fresh tumor tissue at the time of debulking surgery. And we've also subsequently acquired it on some patients after neoadjuvant chemotherapy or at the time of recurrence. There was a short phase, although it's closed right now, but there's a short phase where we were generating patient-derived xenograft models from that tissue, as well as performing direct single-cell analyses on those. We'll talk a little bit about that as we go through the methods and our data. So on the bulk side of analysis within the OCPMI, we're using a number of different methods and approaches to understanding both our patients and their tumors. So from Germline, what we've developed in the clinical molecular diagnostics lab over the years, for the bulk of the project right now, we were using what was called Illumina's TrueSight 1 Germline panel. It's essentially a mini medical exome of biologically and medically relevant genes, about 4,800 or so. And so that is a single DNA-seq capture panel. And the way that the clinical lab performs it is we capture everything and we informatically blind ourselves to the clinical order, but it provides a nice research backbone so that we can do other analyses on it. In addition, we've been doing somatic bulk sequencing, DNA sequencing of the tumor using either whole exome sequencing with Agilent V6 whole exome capture kits, or focused panel-based testing with Illumina's product called the TrueSight Tumor 170, which is a 170 gene panel. We're hoping to expand that to Illumina's new product, which is TrueSight Oncology 500, and again, 500 genes there. In addition, we've been performing somatic tumor bulk, whole transcriptome bulk RNA-seq, again, just kind of as a backbone and a gut check against what's known, particularly from the TCGA subtypes. In collaboration with the University of British Columbia, we have been performing nanostring molecular subtyping. So Mike Inglesio up at UBC has developed a single patient assignment validated method using nanostring technology to subtype the 4 molecular subtypes, to assign one of the 4 molecular subtypes to each patient's sample. And then we've also been studying immune responses through PD-L1, PD-1, and CD45, immunohistochemistry, as well as my own just histologic analyses of these tumors. On the single cell side, we've been using the 10x Chromium platform to perform single cell RNA-seq of these tumors. And I got to tell you, it has been amazing how much custom bioinformatics development has gone into just trying to understand that data and understand what each cell type is within that single cell data. We've done a little bit of exploration of using DNA sequencing at the single cell level using the Fluidigm C1 platform. I'll just leave it at this. We're trying to figure out how to make some sense of it, but overall the data is very heterogeneous and somewhat mediocre, so I won't say much more about that in the rest of the talk. And then finally, with the University of Colorado, Denver, and Kim Jordan, we've been performing multiplex immunofluorescence staining of these tumors. So we take paired sections and we run them on one of 6 marker platforms, either for lymphoid markers or myeloid and PD-L1 markers. And we can do quantitative computational analysis off of that multiplex IF staining. So that's a new and exciting thing that we're just starting to get some great data off of. So here is the bulk analysis framework that was created in the original phase 1 Grand Challenges project. As I said, the patient would be enrolled in the study at the time of surgery, and a tissue sample would be collected. That tumor tissue would go on for both bulk and single cell omic analyses, both DNA and RNA based. And then the patient blood sample would be collected. We would do the clinical BRCA1 and BRCA2, which of course is reimbursed by nearly everybody from Medicare on up to every healthcare payer that we know. So that would allow us to get some clinical reimbursement for these. But again, we would provide clinical return of results for a much larger germline variant screen panel, as well as secondary findings that those patients would be interested in for themselves and their family. Finally, what we've been doing is trying to develop the framework and demonstrate the utility for pharmacogenomic analysis that can also be performed on that same panel and used to help guide therapy selection and or secondary supportive care therapy selection for these patients. So let's talk a little bit about the germline findings. So right now, the interim analysis where we are with that is last done by Wee-Wan Lee was 36 patients. So as I said, we were basically using this primarily to do a expanded ovarian cancer predisposition panel of 26 total genes, BRCA1, BRCA2, as well as 24 additional genes. Again, very common, probably very similar to the BRCA panel that is done up at the University of Washington. Those genes are listed up here. When we looked across that first 36 patients, we found that approximately 15% of our patients had a germline genetic predisposition driving their ovarian carcinoma, and this is pretty consistent with what is known about ovarian cancer right now. 8% of those patients, or a total of 3 in the cohort, were BRCA1 positive. 2 of them were BRCA2 positive, and 1 of those patients was positive for a mutation, pathogenic mutation in BRIP1, which is, at least to me as a protein biochemist, better known as BOC1, a helicase that interacts with BRCA1 and is part of the homologous recombination DNA repair pathway. And as Colin nicely laid out for us, these types of alterations are predictive for PARP inhibitor response. And in fact, again, in the ovarian cancer setting, the germline BRCA1 and BRCA2 mutations seem to have the best overall association with PARP inhibitor response. And also, again, as Colin nicely set up for the audience, there are additional homologous recombination DNA repair genes like PALB2, as he mentioned. BRIP1 is also in that family that may well indicate PARP-I responsiveness. But again, this is something that is a very active part of investigation right now. Turning away from what we considered the primary ovarian cancer predisposition portion of the project to what the secondary findings were, when we looked at the ACMG panel, so again, normally that's considered a 59 gene panel, but of course BRCA1 and BRCA2 are 2 of those 59 genes. When we looked at the other 57 genes, we found 2 patients carrying pathogenic alterations in a gene that is quite actually important to patients who are undergoing 8 to 10 to 12-hour surgeries in the ryanodine receptor, RYR1. And so this, of course, is a germline predisposition to a very poor reaction to inhaled anesthetics known as malignant hypothermia. And so actually the scary part about this is that the way that the project unfolded, we actually found those after their initial surgery. But in both of these cases, that was actually reported back into the patient's medical record, and their subsequent surgeries and subsequent debulkings actually have allowed them to be managed more appropriately based on that finding. Also, across that 36 patient cohort, I should note that virtually every single patient wanted to learn more about their potential reproductively significant findings, basically carrier testing. And we found 9 of the 36 patients who were carriers for what would be considered normal kind of germline screening testing for recessive inherited disease. We also performed an analysis to understand if extended cancer risk testing would actually help these patients. So we looked in a research mode at a much larger 95 gene inherited cancer research panel. 21, within each patient, we identified 21 rare variants. And now many of these were silent or intronic, but amongst the 36 patients that we looked at in this part of the cohort, there were 88 total coding variants that were rare and would need further workup. 10 of those were known ClinVar pathogenic. All of them had been already reported in the return of results component of the project within the 26 genes associated with ovarian cancer risk. And actually, caveat to that, 2 of them were actually in CFTR, cystic fibrosis gene, which actually has some associations with GI cancer risk. The remainder of these 88 total variants were classified as abus, except for 1, which was a pathogenic mutation in MSH3. And this, of course, actually is not diagnostic of a cancer predisposition status alone. It's actually a recessive familial adenomatous polyposis 4 syndrome. And so it's simply carrier status. And this does not actually explain this patient's ovarian cancer. So our germline pilot cohort data suggests that there's limited utility to large inherited cancer predisposition testing, at least in our patient population. It did provide a significant increase in workload complexity. So we've also been looking at pharmacogenomics analysis. And again, I just want to, in the interest of time, say that what Zach Rivers has done is developed a workflow with Sarah Monroe to quickly filter our data down to clinically actionable alterations. Across 25 patients that were in Zach's last analysis, there were 42 total variants that had level 1A, which is the highest level of CPIC guidance for pharmacogenomics actionability. Some examples of that include alterations in CYP2D6. So about 13 of our patients had CYP2D6 alterations, and about 4 of our patients had CYP2C19 alterations. And so these are pharmacogenomic guidelines, high level, that would guide the dosing for ondansetron and SSRIs, which are commonly used in the chemo cancer patient population as supportive care. Getting back to the quality of having good local analysis of data, so we've done a small sub-cohort of 16 patients where we compared our focused 170 gene panel TST170 to whole exome sequencing on bulk DNA mutation analysis. The thing that you want to draw your attention to is when you do bigger panels, you lose coverage. So it's obviously, it costs more to cover more deeply, and coverage is a key driver of data quality. And so you can see this comparison where when we looked at our whole exome sequencing data versus our TST170 data, the fraction of exons that had achieved at least 100x in our whole exome sequencing data was only 60%, whereas it was greater than 99% of our data. And very briefly, what the figure on the right-hand side shows you is, again, that the overall concordance between a focused, higher depth coverage panel like TST170 versus a lower depth but broader whole exome sequencing panel shows that there's not a great deal of concordance, only 54% overall, with more accuracy and more concordance seen when we look simply at the TST170. So data quality is a challenge, particularly when you're looking at heterogeneous tumors and you're interested in variants which may have very low variant allele fractions in your data. Your variant caller matters. So when we looked at our whole exome sequencing data, we compared 3 different types of variant callers in the bioinformatic pipeline. MUTEC2, which is a little bit more conservative and has a number of additional quality filters built into it, versus 2 callers which were a little bit more permissive, Pisces and Freebase. And what you can see when you look at how large these numbers are, when you look at the intersection of all 3 callers, only 4,482 variants across 32 samples were actually concordant. Also, again, like Dr. Pritchard showed, your molecular pathologist matters, your expert review matters. So when I looked at 16 patient samples with TST170 data, that was pre-filtered by our pipelines in Anavar down to 172 variants of possible clinical significance. However, only about a third of them actually passed my quality review. Many of them actually failed, and more importantly, when I was doing quality review, looking at IGV, I picked up a couple of types of variants, particularly medium to large size indels of several hundred base pairs that were miscalled by the automated pipeline that molecular pathologists can pick up in a manual data review. The other key thing that I want to show when we talk about the clinical value, just as Dr. Pritchard had showed, is there's a significant value to doing paired germline and tumor sequencing. So when we look within that cohort,
this time.
So when we look within that cohort at the number of genes that are pathogenic and likely pathogenic, there are 25, and a quarter of those were germline. And importantly, all of those variants that were detected in the somatic data that were potentially related to homologous recombination deficiency were germline. So again, it kind of gets down to how do we try and crack that nut of detecting homologous recombination DNA repair. So we've also looked at our bulk RNA-seq data. We've used a technique that uses unbiased discovery of gene expression patterns called weighted gene co-expression networks. And basically what I'm going to show is, again, this is a way to try and find correlation of gene expression with different types of clinical pathologic characteristics. The important thing is that, again, we can find a lot of correlations in bulk RNA-seq with stage, with recurrence, but the critical one that we found no associations with is platinum status. And that's why we want to descend into the single cell. And so what we've done with single cell sequencing is we've taken fresh tumor samples from the operating room. We've gone through the 10x genomics platform. And then, as I've said, we have had an army of computational scientists try and understand how to process that data and understand it. One of the key things that I want everyone to take away about single cell sequencing is that the majority of messenger RNA in any individual cell is not detected by this technique. So it takes a very thin slice, detecting only about 5 to 10% of the total transcript within any individual cell. But its power is that we can then understand on a cell-by-cell basis what each cell is and maybe which types of pathways are active in that cell. So when we do our single cell analyses and we identify the proportions of different cell types within each one of our patient samples, we currently have done over 74 samples from 54 patients. There is a lot of heterogeneity in the individual cell types. Down on the bottom parts of the graphs, you can see immune cells. The red is fibroblasts, the blue and the pink and the dark blue are different types of epithelial cells. And you can see that there's a tremendous amount of heterogeneity. And this highlights why bulk expression is inconsistent in trying to identify truly biologically and clinically relevant pathways. So now, and this is the most exciting thing that I'm going to take my last minute for, so don't cut me off, Bharat. The most important thing that we've been doing is actually comparing samples for which we have single cell data for pre and post neoadjuvant chemotherapy patients. So what we've been doing is looking in the pre-component, and these are UMAP projections of the different types of cell clusters that are created by the informatic algorithms. And you can see that this heterogeneity of different, distinctly different types of epithelial cells, colored down in blue in this lower part. When we look at that same patient, after that patient was given neoadjuvant chemotherapy, there's a different number of clusters within that epithelial component. And importantly, what we see, we can actually use Spearman rank correlations to track back that post-neoadjuvant chemotherapy population to what types of clusters did it most reflect in the pre-setting. This blue one that you see right here, which is very small in the pre-neoadjuvant chemotherapy setting, expands to over 20% of the tumor burden in the post-neoadjuvant chemotherapy setting. So now with the single cell technology, we can start delving into what are the biologic pathways in those residual distinct subsets of epithelial tumors. We can do it also with the tumor microenvironment, et cetera, to try and understand what might be some of the drivers of therapy resistance. So given the parts on time, or the limitations on time, I'm going to skip over what we're doing with the immune, just outside of showing some beautiful pictures of CD8 positive T lymphocytes on the left-hand side and PD-L1 positive CD68, CD33 positive macrophages on the other side. So hopefully what we'll be able to do with this technology is spatially resolve densities of different types of immune cells and understand better how these patients might respond to checkpoint inhibitors. So in my 1 minute over, what I hope we have shown you is that germline genetic analysis based on broad NGS can be optimized to deliver better clinical value to our patients. Moderately sized somatic DNA-seq cancer panels can capture genomic alterations associated with homologous recombination deficiency, either by capturing BRCA mutations, other homologous recombination pathway mutations, or as Colin showed us, genomic loss of heterozygosity. And finally, we're hoping that single cell analyses, whether it's at the RNA-seq level or the multiplex IF level, can help us understand the complex underpinnings of platinum resistance and disease progression. A huge thank you to everybody. It took an absolute army to do all of this work. And here's your moment of Zen.
All right, Dr. Nelson, we have just one question for you. Have you started to look into the metabolomic or proteomic profiles of these tumors?
Fabulous question. We have not delved yet into the metabolomics component, but we are working with a collaborator whose name I have forgotten, and Boris is amazing at driving collaborations internationally and nationally at proteomics and attempting to see with some of these fresh frozen tumors if we can do phosphoproteomics as well.
All right.
Thank you, Andy. That was a wonderful talk.